Okay, it says Sarah up there, but I'm commonly called Sherry, a nickname from childhood. And I am the president of the Washington chapter of PNHP Washington. And I want to welcome all of you who've come to our February monthly meeting, where we've got a wonderful speaker coming that Hugh will be introducing. And land acknowledgement, I actually am sitting on Mercer Island in Lake Washington near Seattle. And it had, and once upon a time, two villages from tribal members from the Snoqualmie tribe. So I guess we could call it Snoqualmie land at one point. But the rest of the area here in Seattle is the tribes moved up. They had canoes that went up and down the Salish Sea. And they each had some villages here and there, and they did a lot of trading and sometimes fighting. But the whole area was very active in Northwest Native American tribes of various kinds. And now we have their legacy. David, who's next?
Well, I'm just going to quickly lay out the order of business tonight. And there's a bunch of people here, so rather than self-introductions, it's best to put your name in the chat and where you're from and what organization you're with, if you're with one. And you can put your pronouns in there if you like. Hugh Foy, our new national PNHP board member, will be introducing our speaker. And after our speakers talk, we'll have a discussion Q&A period that Hugh will moderate, and you can ask questions at that point by raising your hand. So another thing, there's a big event coming up. There's going to be a rally on the Capitol steps in Olympia on March 6th from 11 a.m. to 1 p.m. It's the next to the last day of the legislative session. So we're going to be talking about what we need in the way of healthcare coverage for everybody. And if there's been some movement ahead in the legislature, we'll talk about that. And otherwise, we'll make plans and asks for what we can do to push things forward. I think there's going to be something like at least 12 different organizations that are going to co-sponsor this, including us. And there'll be speakers there and music and posters, and Backbone Campaign is going to have their famous vultures. But anyway, that should be worth going to. Bill Bronson is going to be the speaker at our monthly meeting, March 20th. I've known Bill for 60 years, and his whole life has been devoted to pushing for treatment and so on of the underdog, the disadvantaged people, and particularly in the disabled community.
Well, it's a great honor to introduce our speaker tonight. When I think of Steve Bezruchka, or Stephen, I see him standing in the Harborview ER when we were both junior residents. And you were my orthopedic consultant when I was an intern there, shaking in my boots, and you were always a calm and sage presence. And so I have fond memories of Stephen, of our time together, and have followed your journey through many trials and tribulations and challenges, and enjoy your perspective on health and healthcare. For those of you who don't know Stephen, he was born and raised in Toronto, the son of immigrant Ukrainian parents, and his father, the cobbler, and took care of the family, and they lived above the shop. And Stephen had a lot of different challenges in his life. The first being, as he remarks in his book, the untimely death of his younger brother, who was 4 years old, which impacted his family a lot. But Stephen went on to great things. He went He got his Bachelor of Science in Mathematics and Physics at the University of Toronto in 1966, went on to Harvard to get his master's degree in mathematics in 67, and then went out west to after some travels to Nepal and elsewhere, but ended up getting his MD degree at Stanford University in 1973. I guess it was after that that you did a lot of your trekking, Stephen, before you came to Seattle and started your first residency in orthopedics, and then took some time out for some interesting reasons, mostly your health that you allude to in your book, that I remember it very well, our time together. Stephen then trained in emergency medicine and has practiced around our community, and has joined the School of Public Health, where he now is a senior lecturer emeritus and the author of several books, some incredible publications. Is a very sought after speaker, and also has, to his credit, not one, but 2 TED Talks. So Stephen's going to talk to us tonight and address a lot of this. I know this is backwards because of the camera business, but this is Stephen's latest book, Inequality Kills Us All, how COVID-19's health lessons for the world. So without further ado, Stephen, thank you so much for your time. It's great to see you, and we look forward to hearing what you have to tell us.
Thanks very much, Hugh. Yes, we were residents together, and then you continued on, but the lymphoma I had contracted recurred, and so I didn't want to die holding retractors in the OR, and somehow I'm still alive. So let me share my screen, and I would be happy if you could interrupt me at any time if you want clarification of something or you disagree with me, because I have spent a large part of my life providing health care, and then I wanted to understand more about health. So this is what I'm going to talk about tonight. So let's see if this will work. So yes, with the land acknowledgement, it's nice to hear this, but so far we're not doing very much about it. I think we have to put some traction into the words, and how that's going to come about, I don't know. So a little more about me. As Hugh said, I went to graduate school in mathematics, and I decided to leave that. And I had befriended somebody at Harvard who was working at USAID in family planning in Nepal. So I showed up at Dan Taylor's house, and he gave me boxes of condoms and said, distribute these in the hills. This is 1969. Well, I wasn't going to demonstrate how to use them, so I blew them up as balloons for kids, and they played with them in these amazing mountain backdrops. I then wrote the first trekking guidebook to the country, which now this is the 8th edition that came out 13 years ago, but I'm too lame to revise it, so that's it for me. I then, after medical school, went back to Nepal to try to teach local people locally to provide services that would deal with their problems. And I worked a week's walk from the road. And when I was doing a plastic surgery rotation at Santa Clara County, the plastic surgery fellow asked me what I wanted to do, and I told him about wanting to work in remote Nepal. So he told me to learn to cut skin grafts with razor blades. So, you don't need a dermatome. All you need is a razor blade, and when they get dull, you can get another one. So I'm on the right teaching Pema on the left to harvest skin with a razor blade. That was in the 1970s. In the 1980s, I had the good fortune to set up a teaching hospital in a remote district for Nepali doctors. And again, I tried to teach rather simple skills such as open drop ether. There was no electrocautery and no oxygen, so it was a safe and effective anesthetic. Then in the 90s, I got obsessed with what you're going to hear about tonight and tried to get in as many venues as possible to talk about it, including this TEDx talk at UW some years back. My family, my wife, son, and daughter, and I now have a 6-month-old grandchild. I'm a grandpa for the first time. So I want to ask, how healthy are we in the United States? Look at the impacts of medical care on health, and then lay out a prescription for what needs to be done. So about 25 years ago, I coined the term Health Olympics. Suppose health were an Olympic event, and the race, remember countries compete in Olympic events, the race was how long you lived, life expectancy. So if the race was life expectancy, anybody out there give us the gold medal. Just to frame this, we spend half of the world's healthcare bill. I'll get to that later. Anybody give us the gold medal, longest lived country?
No,
Anybody put us in the top 5?
no,
Anybody 6 to 10?
Nope.
nope,
11 to 15?
Nope.
16 to 20?
Nope.
Really? 21 to 25?
Nope.
nope,
26 to 30?
Nope.
Come on, below 30.
below 30.
Okay, well, so I've been using the same data source since I started doing this, the United Nations Human Development Report. And these are results from Table 1 for 2021 in the 2022 UN Human Development Report. And I've listed the top 45 countries. There are a total of 190 there. And I've arranged them from the left, the longest lived country, down to Estonia at number 45. And you can see United States ranks 44th in our life expectancy, average length of life. This is period life expectancy, average length of life if mortality rates didn't change. So ahead of us are all the other rich countries and some not so rich: Chile, Thailand, China, Barbados, Slovenia. So we live shorter lives than people in a lot of other countries. And I want us to reflect on why this might be the case. Can't be healthcare, since we have such a sophisticated and expensive healthcare system. So it must be personal behaviors, right? Well, out of all the countries on this list, which country has the smallest proportion of men smoking cigarettes? I think most of you agree smoking cigarettes is not that healthy. Which country has the smallest proportion of men smoking cigarettes?
The United States.
United States and Sweden, that's right. About 15% of men smoke in this country, and Sweden about the same. Which country on this list has the highest proportion of men smoking?
Japan.
Japan and China. They have about 45 to 50% of men smoking. So if I told you that's the reason Japan's so healthy, they all smoke, you'd be wise to tune me out. So we're looking at a 7.5-year difference between the United States at 77 and a bit and Japan at almost 85. So what does that 7.5-year difference translate into? If it's a few more years drooling in a nursing home, maybe I don't want that. But so how can we operationalize that difference? Well, what's our leading disease killer?
Homicide.
No, it's way down, but it's heart disease.
heart disease, right?
Number 2, cancer. And in 2021, number 3 was COVID. Suppose we eradicated heart disease, cancer, and COVID as causes of death and kept the other disease death rates the same. We would be number 2 or 3. We would be close to Japan, but still not the longest lived country in the world. So I would suggest that the difference is huge and meaningful. Now, the life expectancy numbers have been increasing steadily. It's one of the miracles of the last century. Health keeps on improving. Well, back in the 1950s, when the numbers, the numbers of years was much lower, we were somewhere in the top 5 or 10, depending on which year you looked at. So our health used to be among the best in the world. And what has happened is we've seen larger improvements in health in other countries than the United States. So when I went to medical school in 1970, we were 17th, around where Israel is now. When I went to public health school in 1992, we were 22nd. And in 2019, we were 36th. So that's sort of the trajectory that we've been seeing. We rewind back, say, to 1980, and the gap between us and the average of the rich countries was not that big. But you can see around 2010 or 2015, life expectancy plateaued and actually started going down. And notice some of the other countries saw a little dip, but nothing at all like ours. And by the other countries, I mean all the other rich countries. Now, the CDC reported that we had a slight increase from 2021 to 2022. So we've had a little bit of a rebound. But when the newspapers report on it, this is really the interesting thing. They point out we have a life expectancy crisis, but it's not a political priority. You will not hear any politician speaking about our being dead first. It's just not something that anybody wants to get into. So we can look at life expectancy at a variety of different subunits within the country. So at the University of Washington, there's the Institute for Health Metrics and Evaluation, and they produce all sorts of data. And this is life expectancy by U.S. county in 2014, with the red being the lowest and the deep blue the highest. And notice there's a 20-year gap there between the lowest and the highest. So 7.5 years is heart disease, cancer, and COVID. This is really hard, very hard to characterize in meaningful terms, other than it's huge. So where's the deep blue? You know, the deepest blue is not too far from the deepest red. So you see the red in the upper middle in Pine Ridge, where Pine Ridge Indian Reservation is in South Dakota. That's where the lowest life expectancy is in the country. And among American Indian men, it's in the high 40s, and for women doing somewhat better. When you average everybody out, it's a little more like 68. And you go about 200 miles southwest to the purple, and that's Summit County in Colorado. Highest life expectancy among counties in the country, and that's where all the rich people live. Richer people are by and large healthier than poorer people. Notice on the lower left is Alaska and the islands of Hawaii. And I want you to remember, Hawaii has a pretty even concentration of good health there, and it is our longest lived state. and I will refer to Hawaii later to try and understand how they see health production. So this is 2014. Their latest graph is 2019. And I want you to see that the blue on the left, 2014, has sort of disappeared in great amounts, and the red or yellow, the lower life expectancy, has been increasing. So we've seen a decline in health across the country over that 5-year period. Well, let's take the latest data, and this is 2020 life expectancy by U.S. county. And once again, I want to look at the distribution of blue and red. The Midwest, upper Midwest, a lot of blue there, except for the red where the Indian reservations are, is one thing. And then the other, notice the Mississippi Valley. A lot of red concentrated there. Appalachia, the area south of Lake Erie, and the southeast as well. So again, a 20-year difference in life expectancy within the United States among U.S. counties. I want you to put and by the way, any questions at any time, please blurt them out. So I want to have a show of hands for the next part. Here are 10 factors that I want you to arrange or think about in terms of most important for producing health and least important. So how many think built environment is the most important, is really important? How about childhood conditions? Culture, education, employment conditions, genetics, healthcare, income and wealth, politics, or social support. So a study was done in 8 countries, internet surveys of a sample of the population, asking them to rank these 10 items in terms of what matters for good health. And this is how the people in the US ranked them. Number 1 was healthcare, and the last was politics. And for the other 7 countries, only China, upper right, did not rank healthcare as number 1. So the American public believes that healthcare is the most important factor for producing good health. So we should ask, well, what are the determinants of health? What determines health? And let's take our healthiest state, Hawaii, and it produced a report called Chronic Disease Disparities Report 2011, Social Determinants. So that's the title page by the Department of Health in Hawaii. And the mountainside metaphor you see on the left is on page 2. So they put it right up front. And I want us to explore that, Hawaii is a mountainous state, and a lot of it looks sort of like this. So let's look at Makai to the water, downstream effects, and then let's trace the river up past the waterfall up to the root causes, or Mauka. You ready? So what's downstream? Well, it's all the chronic diseases, asthma, cancer, heart disease, diabetes, and so on. If you're not suffering from them yet, you will soon. So Hawaii puts the chronic disease burden into the ocean, very far downstream. And what's on the shore above that? Well, the traditional risk factors: smoking, physical inactivity, obesity. So Hawaii, again, the Department of Health, thinks these are Downstream, not so important. What's on the other side of the river flowing into the ocean? Healthcare, the work that we all do. Hawaii seems to think it's less important. So let's go upstream a little. Oh, and just to drive that point home, here's a graph of 10 countries' life expectancy over the 20-year period after 1995, and their spending on healthcare in purchasing power adjusted dollars. So the healthcare expenditures are consistent among the countries. And of course, the red arrow indicates the United States spends a lot, doesn't have long lives. You can tell which arrow has to be Japan, the longest lived country, spending considerably less than we do. So I've been searching for another metaphor for the work I did for most of my life, and I came across this one. We healthcare workers are busy mopping up the floor. We just are sweeping away the water, and we can't keep up with the flow. What needs to be done?
Turn the water, turn the water off.
Turn the water tap off. But whose job is that in this country? Nobody. I see Deborah shaking her head. It's nobody's job. You don't want to mess with such a huge economy. It's 1/6 of our total economy, and we can't mess with it. So we just keep mopping up the floor. Let's go back to Hawaii and where the waterfall is. So the phrase social determinants of health has come into use in the last decade or so. And these are the non-medical factors that have a profound influence on health: discrimination, racism, poverty, pollution, geography, education, income, wealth, occupation, employment. So they're rightly situated as being very important because that's where the water's cascading. But what's above that? What does Hawaii see as the root causes, the upstream determinants or mauka of health? Well, socioeconomic conditions. And what's above that? Political context and governance. Remember the internet surveys? Everybody ranked politics last. But if Hawaii's correct, politics should be ranked number one. And I think that's been, to me, the great revelation that I have undergone since I began asking this question: what produces health in a society? The reasons are mostly political.
Isn't there an equation, Stephen, between political context and wealth? Because the politicians are all taking money from the top 1%.
Absolutely. So for example, so how does I mean, we live in a country where the politicians are bought by the very rich. The Citizens United Supreme Court decision allowed unlimited contributions to politics, and the richest people basically buy the government. And I have only until 8 o'clock, so I could go into that a lot. But who pays the lowest taxes in this country? If you take combined federal, state, and local taxes, the richest 400 pay the lowest rate of tax, 23%. Back in the 1950s, when we were one of the longest lived countries, they paid over 70% of the tax.
Yeah.
So we've decided not to tax the rich.
Seems
Let
to
them
me
have
that
all their spoils.
if you talk about political context, then you're talking about the profound discombobulation of the American public. They're
Yeah.
not organized. And to that
That's
extent, they represent the political context that doesn't move the government.
A very important point. So if we want to change our health status, we have to enter the political arena. And as I said, no politician talks about our health as a country. Hardly any news media do either.
Yeah, Bernie
Well, we
and
can break.
Jayapal.
Oh, sorry.
Bernie and Jayapal.
Yes, I'll. Uh, she she does, and Bernie does, and I'll bring up somebody else who does later. Well, we are if we break the data up by race ethnicity, I'm just pointing out what we looked at earlier. American Indians have the lowest life expectancy. And if we put that into the UN list of countries, they would rank 145th. Remember, we rank 44th. African Americans don't do so well. Notice that Latinx or Hispanic do better than we gringos and gringo. And that's a fascinating subject. It's called the Hispanic paradox. And if I try to conceptualize that in my experience as an emergency physician, I never saw a Hispanic patient in the ER. I saw a whole bunch of people crowded around a gurney, and inside was the patient, and around them were all the friends and family. Meanwhile, here's a white guy over here moaning alone. So although they're not particularly wealthy and rich, they have a tremendous amount of social support they offer to one another, and that buffers the adverse effects of not being rich. So, like I said, it's a huge expenditure. Pretty well close to half of the world's healthcare bill we spend in this country, almost 13,000 per person in 2021, a sixth of our economy. It's huge. So what do the studies show on the impact of healthcare on averting mortality? Well, there's a fair amount of scholarship on that. And I offer you one paper from Stanford that looked at a variety of estimation methods on how much medical care averts premature death. And they come up with a figure of 10%. And that's certainly consistent with what Hawaii says. It's consistent with a variety of other sources. Medical care really amounts to about 10% of the impact on health. So I want to leave that behind and ask another question. And that is, as we go from the erection to the resurrection, it's the period in early life, the first 1,000 days after that zygote, after your mother's ovum is fertilized by your father's sperm, in which roughly half of our health as an adult has been programmed. So early life lasts a lifetime in that sense. And why might that be the case? So the fetus is inside the womb, monitoring the outside world to see whether or not it's a nice, friendly, nurturing world, and I can develop all my organs fully and come out with a decent birth weight and be nurtured and survive to reproduce. Because from an evolutionary perspective, we only have one purpose in life, and that is to survive, to reproduce, and not pay the price, and pay the price with chronic diseases in later life. That's the evolutionary perspective. And so if the fetus senses it's a hostile world out there, that I can't, I don't have time to develop my lungs and my kidneys and all that, I'll pop out early and be ready to survive, to reproduce. And who cares about the chronic diseases that I'll suffer from later? And you know that as clinicians, because if you're faced with a preterm delivery of an infant, you give the mother prednisone to mature the fetal lungs. So a student of mine did an Ignite talk at town hall on the first 1,000 days. And this was the graphic she used to illustrate the first 1,000 days. From conception by the time you're blowing out 2 candles on your 2nd birthday. That's 1,000 days. So healthier countries privilege that period. And how do they do so? Well, one thing they can do is give a pregnant woman who has a job, who's working, paid time off after she has her baby. There are only 2 countries in the world that, with populations of 1 million or more, who don't give a working woman who's pregnant paid time off as a national policy. One is, of course, the United States, and the other is Papua New Guinea, half of a big island north of Australia. So that's one thing we could do, is let's have a national paid parental leave law. Washington State has one, but it's pretty minimal. We must recognize the importance of class. So the class gradient is pretty well in everything that is related to health. And the Titanic presents that very well. If you had a first class ticket, you 60% survived, second class, 40%, third class or crew, a quarter survived. So always ride first class, or better still, let's not have any class distinctions. So I like to simplify things. And so the more inequality we have in society, the more problems we have. And this is the textbook I use in my courses, in addition to my book, The Spirit Level, Why Greater Equality Makes Society Stronger. And on the left are 10 health and social factors that are presented as z-scores. If you have any biostatistics, they're multiplied together from lower being better to upper being worse, and income inequality, a standardized measure. And the genius of the authors was taking units off the graph, because as soon as we see a lot of numbers there, our eyes gloss over and we fall asleep. So the United States, not unsurprisingly, has pretty well the worst outcomes there among the 23 rich countries, and that correlates with the high income inequality. Now you're sitting there thinking, oh, this is all nice and good, but it doesn't apply to me. So the hardest thing that I have to do is to convince you that it does. And I'll just show you one graph to try and convince you. And this is a graph of mortality rates in the age group 20 to 64, comparing US blacks and whites, the red triangles being blacks and the blue circles being whites, with the 6 countries you see down below on the right with their graphs. And poverty ranking goes from, on the left, rich to where 100 means poor. So if you take the best blue, US white, notice that it's much higher than the line for the other 6 countries. And the gradient I mentioned before with the Titanic shows how much worse off we are. And you can show similar results for all the different age ranges, but it's still very hard to convince most Americans that they're going to die younger than they would. However, I'm always looking for new ways of expressing it. And this paper occurred last year, saying that if we had half of all deaths of people under 65 would be averted if they lived in countries like Australia, Canada, Germany, Japan, or Portugal. So think about that. That's sort of like 11 million excess deaths over that period of 1980 to 2019. if you multiply it out, that's about 773 deaths a day, 2 jumbo jets crashing every day. That's the price we pay. So what really matters? Well, I've tried to suggest that healthcare, spending money on healthcare doesn't matter, and that spending money on social expenditures probably does. So this is a graph by Elizabeth Bradley at Yale, where she took social expenditures of the other countries and divided them by healthcare expenditures. And you can see we spend more than twice as much on healthcare than on social expenditures, and that's really not productive of health. So what do other countries do for social expenditures? Well, I mentioned paid parental leave, very free or low-cost child care, sickness benefits, free education. You know, medical school is free in the Western European countries, living wages, and so on. So we could learn from the other countries. And, take, well, in Canada, you get a year's paid maternity, paternity leave at 60% to 70% pay. It varies from the provinces. And the employer, that's paid from unemployment insurance, and the employer often tops it up. Sweden's even more generous, and daycare there is free, and so on. Well, we can look at US state trends in life expectancy to try and even bear down some more. So this is from 1957 to 2017, where the green are US states, the ones on the bottom, with conservative state policies, and the ones on top, you can tell which one is Hawaii, the longest lived, are liberal state policies.
Hmm.
So there's a lot you can do at the state, and I notice since you're going down to Olympia, there are levers that you can push and pull to do something about health in this state. Now, Washington has actually improved its health beyond 2017. So it's now just behind Hawaii. So there's been some good work done in this state. So what are we going to do about this? Well, Frederick Douglass, an escaped slave and abolitionist, said a long time ago, it's easier to build strong children than repair broken men. But that, again, we have a huge industry repairing broken men and women, and so far at least we don't want to tamper with that, even though we don't have universal coverage and all the other things that you work for. So again, I like to simplify things. What do we need to do? We need to care, we need to share, and we need to repair. So let Papua New Guinea be the only country without a paid parental leave policy. Let's have health care for all, free schooling, childcare. You know, I had a graduate student who went to Montreal after he finished his PhD, and he had a baby, and he told me he paid $8 a day for childcare in Quebec. So, you know, there's a lot we can do to learn from other countries. We can share, and by that, back in the 1950s, the pay ratio between the highest paid, the CEO, the boss, and the entry-level worker was around 10 to 1. So we could tax the rich and get back to that pay ratio. We could put a wealth tax out there. Rent income is income for which you didn't work, so we could go back to Henry George, who was very popular 120 years ago, who talked about land value taxation and not relying on that rather than taxing income. Sorry. Finally, repair. You know, we've done all the damage to the American Indians, policies of genocide. The slavery was entirely a very exploitive endeavor. And so if we inherited the wealth of our forefathers, do we not also inherit their sins? Do we owe something for that? So William Darity at Duke University writes about a program of Black reparations to take excess white wealth in the US and transfer it so that an African American who had one slave ancestor receive enough to eradicate the racial wealth gap. And the racial wealth gap is huge. Basically, African Americans have no wealth, and whites, their levels of wealth are a couple of $100,000. So we need to do something about that. I serve on the board of Washington Physicians for Social Responsibility. And so consider in joining that. And because we work for nuclear abolition, climate crisis, and economic inequity in health. And the graphic on the right, I actually have on the back of my clipboard. So if I'm talking to people, I hold up my issues as a way to try and convince them what to do. Another thing to consider is social prescribing, or maybe political prescribing. So let's hear from somebody. Canada does this in a bigger way.
Social prescribing acknowledges that people's lives, what influences their health, goes far beyond what happens in the clinic or the hospital. It involves feelings of connection to their community, social supports, ability to pay for nutritious food, caregiving responsibilities, and so much more. And all of these social factors actually form 80% of health.
The impact of a widely spread social prescribing system would allow room for more people to be seen, because it's important to remember that not all healthcare needs are best met at the doctor's office, that sometimes they are best met outside of the doctor's office with human connection.
Full service family practice or primary care is at a crisis point in Canada right now. And one of the issues is capacity. And I think what people don't realize is that social prescribing can greatly increase the capacity of primary care.
We see a lot of patients who have declined and now need help with activities of daily living. And if we were able to intervene earlier by providing them with social prescribing and getting them connected to resources in the community, like exercises that might be acceptable to them, food security to ensure they have a healthier diet, and social interactions through joining community programs, we know that all these things lead to a healthier lifestyle and improve the chances of healthy aging.
But social prescribing acknowledges.
So what are you going to do if you're still practicing? I used to blame all my patients for their bad behaviors that it made them end up in the emergency department. Once I learned Japan smoked the most and was the longest lived, couldn't do that anymore. The social history, trying to understand the whole patient is really important, and you should take a much more extensive social history. I used to talk about these ideas in the emergency department and talk about the status of health compared with other people. And our health decline really has been unique among rich nations. Ask the question, do you want health or health care? Look at our language. It doesn't serve us. We access health, pay for health, get health, insure health. We do nothing of the kind. So I make my students make sure when they use the word health, they're not talking about health care. Join an organization and become an advocate for reducing inequality and creating a healthier population. Maybe we're talking about political prescribing. So here's AOC with her gown, tax the rich. this is the kind of medicine we need. A procedure like this would do far more for improving health. And so we have a lot of work to do. I'll end on that point and happy to entertain your questions and so on. And I'll stop sharing. My email, if you want to email me with any questions, comments, disagreements, there's nothing better than to have somebody disagree with you, because then, you know, he says, she says, what do I think? So disagree, please.
Been a lot of stuff in the recent days revolving around the death of Alexei Navalny of Russia, as well as people in our country who are unduly swooning over how wonderful Putin and Russia are. What do you know about the health of Russians these days?
Very important question. Russia, the Soviet Union broke up in 1991 without much violence or anything. Suddenly, the oligarchs took all the spoils from Russia and became phenomenally rich. What happened was life expectancy plummeted after the breakup of the Soviet Union in 1991, and it is now close to where it was in 1991. And so my concern for the United States, as our inequality has increased so much, is we may be facing a similar transition that Russia did. The little uptick from 2021 to 22 suggests it won't be as profound, but rapid increases in inequality really kill. The counterexample to that is Japan. Life expectancy in Japan was about 25 years after the end of the Second World War, where we firebombed Tokyo, dropped 2 atomic bombs, and then the world's greatest population health doctor, disguised as an Army 5-star general, came to Japan and basically he did 3 things. He demilitarized, he wrote Article 9 in the Constitution saying Japan shall never wage war. They would have to resolve all disputes peacefully. He put a public health clause in the Constitution, Article 23. He legislated a maximum wage of 65,000 yen in 1946, and he broke up the big Japanese corporations, or zaibatsu, and carried out the most successful land redistribution program in history. And the rapid decline in death rates in Japan after that were the most rapid ever seen on the planet. So decreasing inequality can have a huge, really good health impact, and increasing inequality can do the opposite. So we can learn lessons from Japan and Russia.
Well, I'm worrying that our mortality rate will go further decline in this country because of the anti-abortion legislation that has been happening across about a third or half of the country.
Well, let's take Japan as an example. Japan had only one form of birth control until the mid-90s, and that was abortion. Abortion, well, once the men got Viagra, then the women were able to get the pill in Japan. I think abortion, we don't have countrywide data on abortion to know how much it would be impacted with the anti-abortion legislation. But just the fact that we have these wild and crazy ideas suggests there may be an impact there. But I still think
I'm thinking that there's also this assault on birth control as well at the same time. And I just think there's also an exodus of OBGYNs from the states that have criminalized abortion. So, and then it becomes ambiguous as to whether what you're doing as a physician is a crime or not. And so there's just women's health care has really taken a hit in some of these states. And I think it's going to get worse.
Yeah, I wouldn't disagree with you. I would suggest it's a slightly lower order effect than heart disease and cancer. Think about our opioid deaths. That's really up there. 120,000 people a year at this point. I don't think we will see abortion-related mortality into that range. I will say that I sometimes show a picture of my scan of a page of notes I made in 1971 in medical school at Stanford. I wrote that in 1951-53, we had the lowest maternal mortality ratio of all countries, fewest number of deaths of women in childbirth. And now we're one of 11 countries in the world seeing increases in maternal mortality, others being South Sudan, countries like that. So it doesn't bode well for women's health issues, as you point out, whether it will be, and of course, African Americans. Another important thing in that data, we have 4 times the rate of maternal deaths among African Americans than whites. And we tend to think that an education is the way to solve all these problems. You take college-educated African American mothers, their maternal mortality is higher than any educational status for whites and Latinx peoples. So, we have to think of something different than just telling people to stay in school when it comes to maternal mortality. I mean, it's a very important issue. And I think the critical thing we need to do is make comparisons with other countries. A person who knows only one country knows no country. We can only understand ourselves by seeing how we differ from others. Thanks for your question.
One of the things that really strikes me is that there's 3 or 4 or 5 major policy issues which are absolutely absent from the campaigns to transform the healthcare delivery system. One of them, and the most significant one from my perspective, is the lack of public health governance leadership, which is absolutely missing in every single bill in the country at the state and the federal level. Nobody is talking about the need for public health to administratively lead the transformed delivery system. And I'd like you to speak to that. A couple more things I'd like to say. There's a fellow named Jerry Ashton, who essentially has been running a campaign to eliminate medical debt. And we need to buy out all medical debt up front and end the oppressive reality. In the VA system, for example, 22 veterans kill themselves every single day as a result of medical debt, and other, issues that compile on that. The third thing is that we need to fundamentally transform our healthcare delivery system. And so I believe that we need, as you talked about, free medical education, we need to talk about free health education, psychology, social work, dentistry, et cetera, et cetera. And we need to have a global budget to cover the cost of all professional healthcare education in America in exchange for year assignment through a national or a state health corps to underserved areas until we have local comprehensivity. One of the interesting things that the Cubans do, for example, they have this incredible room in Havana that has built out the entire city of Havana in model form. And what they're trying to do, given the crash from Russia, was to localize things so that people didn't have to go for more than 1 or 2 blocks to get anything they needed in the world.
Yep.
You know, and so the whole issue of building an accessible local delivery system and decentralizing the large medical cartel empires is another critical issue that nobody is talking about. And so I'd like to go back to the top issue and ask you, from a public health standpoint, how do we introduce and with the kind of ice pick power, the need for public health governance and to be able to compel the movement to embrace that perspective?
When I went to Cuba and I befriended somebody who taught at the University of Havana, was a doctor, I learned from him that if that they have the polyclinics and the consultorios and all of these decentralized provision of medical care.
Yeah.
And if there's an infant death, the doctor who is responsible for that mother is investigated, and if he or she, because a lot of them are women, were found to be negligent, they lose their job. So doctors in Cuba are in some sense responsible for people's outcomes. There's also in Havana a medical school, ILAM, that takes whose intake is people from many, many other countries, and it provides them with a free medical education and plus room and board and all of that. And they've begun now taking students from a few poor areas in the United States, the Bronx and others. So, this is Cuba, despite our stranglehold that we've had on them. Your point about medical debt, I think it's the leading cause of bankruptcy for an insured person in this country. Makes no sense whatsoever. I mean, you talk to people from other countries and they just can't imagine that that the debt is what it is. The public health in modern discourse, the most progressive public health school in the country is Boston University. And the dean of the public health school there, Sandro Galea, I really respect, because he talks about a lot of the same issues that I do, and partly for the same reason, namely, he wasn't born here. He was born in Malta. And so, he has seen other parts of the world. He wrote a book on illiberalism in public health. And that book has actually made it into the op-ed page. It was just published the end of last year, made it into the op-ed page twice in the New York Times since. So, so I think there's hope. It's hard for me to gauge the morale at CDC, but I don't think it's very good.
Can we challenge APHA? I mean, APHA seems to be so timid and not forcefully addressing the need for their conceptual and practical and professional leadership in this healthcare struggle.
Absolutely. But at the annual meeting in November in Atlanta,
yeah,
I got APHA to agree to sponsor a panel discussion after the keynote on the title was Declining U.S. Health, a Population Health Emergency. And Sandro Galea, the dean of BU School of Public Health, was there. Mary Bassett, an African-American who was New York City Health Commissioner for a period of time. Stephen Wolf, who was the lead author on the Institute of Medicine 2013 report, U.S. Health and International Perspective, Shorter Lives, Poorer Health. And finally, Don Warren, who is an American Indian doctor who grew up on Pine Ridge Indian Reservation. I will try to put the link to the discussion into the chat. Let's see.
Well, that'd be great.
Are you familiar with Rupa Myra, that wrote the book Inflamed?
Yes, It's right over there. A very critical look
Revolutionary.
at the
Revolutionary.
biology behind a lot of this.
Yeah.
Yes.
Wow, this is a great discussion. I put a lot of stuff in the chat. Sorry. I just wanted to point out, a couple of things. We have solutions. It's more how do we adjust the funding and get the leadership. I actually did a public health internship when I was a student at Howard in DC and the National Health Service Corps and how they were laying that out, which is a great concept to provide physicians to underserved areas by forgiving their debt, which might help people to go into the specialties they want instead of having to go into things to pay off this, you graduate with a house mortgage with no house, basically. Right. But the problem there is that, first of all, the number of slots have been significantly reduced, and they need to widen the types of specialties that would qualify for that. Like my specialty, which is physical medicine and rehabilitation, we actually serve as primary care providers for chronically medically complex disabled people that most other people don't know how to deal with. And right now, my catchment, I was just talking with patients today out of Reading, that I get people, they drive 3, 4, 5 hours to at least get a new visit with me, and then I can see them afterwards as a video visit. But that's really not accessible. It's not a place that could support someone starting out on their own with the kind of debt that they might have. So we have this conundrum. I think the whole issue of racism in medicine is huge. And, we can talk about economics all day, but we know the Institute of Medicine report, Separate and Unequal, clearly delineated that even when you standardize for education and income and all of those things, that Black people get inferior and less aggressive care. And I see it every day. I can see it right now. And I have a lady today I walk with that I was so pleased to see, because within 2 days of her coming on the rehab unit, they were saying, oh, she's going to go to a SNF. She's not progressing fast enough. I was like, wait a second. She just got here. And she has too much pain to participate. She was a stroke patient. I said, well, are we treating her pain? And come to find out, the way they extricated her after she passed out from her stroke, she suffered a back injury on top of it. And it was more a matter of like, let's point out, let's provide this woman the care that she needs like everyone else. And I'm happy to say that she is ambulating and she's going home and she's not going to need a Hoyer lift. But it just requires some advocacy and people that are willing to have the same expectations for all patients and value patients the same. And I don't see that enough. I see it all the time. I see the bias. This bias is like so huge. And, how do we teach that out, even when we have well-intentioned people and everything, but we have major biases in our system that cloud the situation. And the last thing I want to point out is environmental issues, which is my real crusade right now. And the whole huge impact of environmental toxicities and environmental exposures and intergenerational epigenetic effects of that, from our veterans to people of color. Something like 52% of toxic Superfund sites are located in communities of color. Yeah. And you look at the historical impact of redlining and where people were crammed into these areas, and then they did illegal dumping and all of these things. And it's coming to light now, but we have to clean that up. Something like 95% of the suits people bring, even when they're fully justified, get turned down. Look at Flint. Thank God it was a pediatrician that identified that, but they still don't have decent water. And, we have to talk about these things and not be afraid or be hesitant. Yeah, I'm worried about Russia and Palestine and all that, but I'm worried about how many people I lost just this last year again that are too young, basically dying because of being Black. Yeah. And so we really, I don't know in what way we improve that framework, but I'm glad to see you have this conversation. Show the data, show it objectively, show how in other places where they're willing to deal from a true population health perspective, which was such a strength during COVID in the UK, Canada, and these other places because they had the data, irrefutable. And more importantly, how do we prepare and anticipate for the impact of artificial intelligence and biased algorithms created by biased people that are already biasing the process? There was another book that was recently written about AI. I haven't had a chance to read it yet, in which that's, her whole premise is like, how do we, we have to get ready for that, and how do we counter that? Because that's going to be huge. I don't have any of those answers, but I think we have to have some consciousness around it and some policy around that as we go forward. I just wanted to, a Black person on the call tonight, I just have to speak up.
Your notes in the chat are terrific, Lisa.
Excellent points, Lisa. David?
I just wanted to make a couple of comments about the Cuba healthcare system. There's 230 U.S. students who have gotten a free medical education there, coming from underserved areas, with the promise that they'd go back to their communities and serve. Right now, there's 23 U.S. students there, and Pramila Jayapal, I think, is in Cuba right now, leading a congressional caucus delegation. And I urged her to have the people that are taking her around there to hook her up to either see Elam or talk to U.S. medical students who are there right now. Delegation, I think, is pretty small with 4 or 5 Congress people, but those Congress people come from other states, so I think they ought to be able to hook up. One other thing, when Katrina happened, Cuba offered, I don't know, 20 or
5,000.
to go in and help, and the U.S. refused to take them.
Yeah, they were offered again after Ian in Florida, same thing. They're in a state of readiness. I do a whole lecture on their whole ability to respond and to prepare and respond to hurricanes and disasters. It's remarkable. And how quick they're back up again. Also remarkable. I want to just say a quick point, probably I'm further monitoring. I just got a message from the Bank of America that I was trying to Zelle some money to a friend of mine that was there on an official mission to film a cultural jazz concert, something like that. Somehow, because I mentioned, so I don't know how they figured that out, that he was going to Cuba, they froze it. And they called me to ask, well, what was this money for? And was this going against, there's sanctions, you can't support business in Cuba. And then they sent me this whole scary message and everything. And I'm like, wow, they are really stopping at nothing here. And this was to an American, not a Cuban. This was to an American before he went.
One last thing, our chapter here has something to do with a trip to Cuba that Bill Bronson put together that Hugh and I went on in 2004. And Quentin Young, the famous healthcare revolutionary, goes way back, was on that trip. So he challenged Hugh and I, why don't you guys have a PNHP chapter? Seattle's supposed to be such a liberal place. So we felt guilty and we got back and we started the chapter.
Yeah.
Oh, way
You
cool. Quentin lives on.
Lisa and anyone else on that trip and subsequent to that, I had many conversations with Fitzhugh Mullen, who many of you know. And Fitz told me about in prior healthcare reform legislation, there was a proposal for a revitalized U.S. Health Service Corps, both domestic and international, and basically to give all health profession students an opportunity, just like we do for the military. Now that's their only recourse, really. I mean, there is still a U.S. Health Service Corps, but it's a fraction of what it once was and what it can be. So some of us are trying to get organized and get a rider onto both Sanders and Jayapal's bill for a proposal for a revitalized and expanded U.S. Health Service Corps, not just for physicians, but all healthcare professions, because we were in trouble before the pandemic, and now we're decimated in terms of not having enough people to staff our hospitals and clinics.
Cuba exports almost as many doctors every year as they do cigars.
Yeah.
People don't know that. I mean,
Right.
Elam has close to 20,000 students. None of them are Cuban. All of them are funded by the people of Cuba.
Right.
And they go back, they're there for 7 years. And then they have to go back to their countries to serve in their people, totally invisible, because the media in this country completely blocks any real news about the miraculous humanitarianism that Cuba exercises in the world.
And we suck 8,000 to 10,000 physicians out of the rest of the world, mostly poor countries, every year into our GME system.
Unbelievable.
Yeah.
So the people own the healthcare system in Cuba. Here, the corporations own the healthcare system. And we have to end that. We have to cut that umbilical cord of money to the cartels.
And the private equity system is buying up all sorts of practices and running them into the ground to sell them at a profit. It's vulture capitalism at work. I want to also just pick up on something else Lisa said. I sort of said medical care in its totality in this country doesn't have a big effect, but if you dissect it, primary health care really is the part of healthcare that you can easily demonstrate works. And we have the smallest number of graduates going into primary health care. And studies in Europe show that the better the primary healthcare system, the more it buffers the adverse effects of income inequality. So it's another tactic to try and play down our specialist system.
Stephen, what should we do? I mean, apart from meeting like this all the time and talking about this all the time, how do we create the ice pick to make the change from your standpoint?
You know, I sort of tell people, do what you have skills at, do what you believe is important, and do what you can do that doesn't take a lot of money. So, you know, I'm reasonably good at teaching, writing, and talking. And I've been doing that for 20, 30 years. I'd like to say we've made progress, but in fact, we're going in the opposite direction. But, you know, do something that you enjoy, because if you don't enjoy it, you won't do it. I can sense among the people here that all of you have things you are passionate about and you have skills at. And the thing to do is to bring others on board. That's the hard part.
Well, you should blog your book, because the last third of your book is about just
Exactly.
what you were talking about. And you didn't cover it all that much in your previous thing, but you know, this is one of the best books I've ever read, and it goes through a whole, you know, what, 20
And the
years?
last 3 chapters are all about our health depends on political choices, prescription needed, and what can we do? And the what can we do is sort of an amalgamation of all the sort of things that I've learned from students and others, different countries over the last 30 years. And I haven't found anything like it anywhere else.
Picking up on Stephen's point that we spend so much money on healthcare, half of all of the healthcare spending in the world, it strikes me that the lever that we're not using systemically is the leverage that the government has over the healthcare system at different levels, like at the state level, for example. So the kind of statistics that Stephen has alluded to and showed us in some examples in terms of particular diseases, if they were built in to the formulas for distributing reimbursement to hospitals around the principle of global budgeting that Bill has mentioned, I think we would have a lot more leverage for healthcare providers to then use different approaches than they are currently using in their interaction with individual patients. I'm a sociologist, so that's my excuse for not paying more attention to the individual level. But at a systemic level, it really strikes me that the mechanism we're using the least is the leverage from public funding. To the extent that government money is paying for half of the healthcare spending, which is itself half of all the medical spending in the world, that to me, through a process of community health planning, would give us leverage. And I think legislation building on that concept could be transformative in ways that are not likely to be utilized by individual medical providers who are balancing, you know, the limited resources they have and the patients they have, and trying to survive as medical professionals, even with the right ethics, the system isn't designed for it. That's why this concept of public funding is crucial. And the privatization issues that Stephen had just alluded to, it's one thing to critique it, it's another to transform it. And I really don't think we're talking about that kind of transformation in the bills, in the national health care bills. When you look at countries that have introduced the national health care systems, they've done it through public leverage. And we are still, not just still, we are declining in our use of public funding. And then you get an organization like CDC, and you realize how politicized that is. And even APHA, we can criticize them all you want, but they don't have the leverage to create the healthcare system that would incentivize good health outcomes. Bill's example of doctors being accountable for the health of their patients in Cuba could be built into community health planning. And I think we would get more traction out of that kind of approach than we are tinkering with our neoliberal healthcare system, which reflects all of the other privatized systems we have in this country.
That's a great segue for next month's meeting, Bob. That's exactly what Bill's going to talk to us about, is their CAPTCHA proposal for meaningful and comprehensive community-based healthcare reform.
Well, I was going to say, after what Bob was talking about, made me think about the government taking all that action during the pandemic. It was somewhat encouraging, I thought. Now, unfortunately, it's all like gone. No more free COVID tests or shots for vaccine or whatever. And in fact, there's a shortage of that RSV vaccine for babies. So, they're ending up getting RSV, being hospitalized. And, it's just like sort of pathetic, really.
Yeah, having it unwind, it reminds us that we still have a job to do. As both Physicians for National Health Program, and also I have my foot in another organization, which is Healthcare for All Washington, which is focused on, maybe we can do it first in a state as an example, rather than just trying to push nationally. So I feel, since I keep both of my feet attached to my body, that both are worthwhile ways to move forward in trying to alert the public. And I had an opportunity today to give a nurse practitioner and Swedish a reminder that PNHP.org exists, and join, and you will automatically become a member of PNHP Washington. So we'll see if she follows through. But that's the kind of thing we need to do, is to spread the word. When somebody working every day in the healthcare system has not heard of Physicians for a National Health Program, we have work to do. Okay.
Well, I think most people who are not physicians would not think about joining PNHP.
I do make it clear that you do not have to be a physician to join.
Right, but it's not obvious. It's not,
It isn't, and we have work to do. So perhaps on that note, maybe we should all say goodnight.
To say one last thing is that this talk was, really refreshing my memory of the book that you wrote about Inequality Kills Us All. And it was, really helpful, and I appreciate it very much.
Definitely, I think all of us should push Stephen's book, because it's just an amazing thing that you can keep around and refer back to. It's the way the chapters are laid out and so on.
So thank you for your attention. I'm really glad we all had this opportunity.
Well,
Thank
we are very glad that you were willing to come and spend your evening talking to us. And thank you so much for doing that.
Okay, good night.
Hey, everybody.
Nice to see you all. Thanks for coming.
Yeah. Bye.
3, 2, 1, 0.